Hello and welcome to our very first event as part of our Conquering Cholestatic Pruritus series. Oh my gosh, what is cholestatic pruritus? We'll get into that. I'm Donna Pryor. I am the founder and CEO of the Global Liver Institute, which is the largest patient advocacy organization in liver health. We have, as part of our convening, we lead the Pediatric and Rare Liver Disease Council. And depending on when you're watching, you may have just participated in that robust multi-stakeholder council, stakeholders of all ages, multi-stakeholder council conversation. We started the Pediatric and Rare Liver Diseases Council to be a home and a hub for the issues that mattered across the pediatric and rare liver disease space, to allow for the elevation of issues that mattered across diseases, try to knock down barriers that impeded research or access to treatment. And so this series really is the result of listening to the insights of patients and physicians on the things that mattered most to them and the ways that the Global Liver Institute could be most helpful. So I am certainly excited to have this event today. Conquering cholestatic pruritus, some people just know it as itching. Why would we have a whole event or spend time on itching? It's much more than that, and my guests will really bring that to life. It is something that is a symptom or a side effect that is shared by more than 70% of patients with cholestatic liver diseases. Those are diseases like primary biliary cholangitis, primary sclerosing cholangitis. And it may sound trivial, but it is a huge issue in terms of quality of life. It is a huge issue in terms of research. And it is something that if we can conquer together, we can go so much further for a very large segment of rare liver diseases patients. So without further ado, I will introduce my guests, Dr. Ramad Anati, who is a postdoc research fellow in hepatology at UT Southwestern in Dallas, Texas. So excited to have physicians with patient experience. That is, oh my gosh, that is just the so powerful thing. We also have Dr. Guadalupe Manrique Maldonado. She is a PhD and science writer and communications expert. Welcome to you both.
Thank you. Thank you for having us. Yes.
Absolutely. And so I am happy to disclose that I'm right here with you. I had PSC before my transplant, and so the issue of pruritus is something that I experienced and at times almost took me out of myself. And so maybe we'll start with you, Dr. Nadi, just telling us a little bit more about what pruritus is and how you've experienced it.
Okay, definitely. So pruritus, in simple terms, is the itch, as you said. I prefer not to go into all the physiological detail about it, given that it's an itch. But it's something very different. So I would like to disclose that I also have psoriasis, and it is an itch. It has an itch, but it's nowhere near cholestatic pruritus.
Mhm.
Cholestatic pruritus is much more severe. It's much more intense, and my experience with it has been quite extensive and harsh.
Absolutely. Guadalupe, tell us about what pruritus how it has impacted your life.
Sure. Yeah, definitely. It's something very different to what people may think when they hear itching. I usually tell my friends and family that think about a burning sensation under your skin or tiny bugs crawling under your
Mhm.
skin, and it's a characteristic that scratching is not going to give you relief. So, of course, it's very frustrating, very detrimental, and it impacts your life in a very, very hard way. So it's definitely very different, and it's very valuable to talk about it and let people know how hard it is.
Absolutely. Dr. Anadi, maybe just a little bit about what causes it. Why do patients with certain types of liver disease have pruritus, and why others don't?
So briefly, related to the rise in bilirubin, and when elevated bilirubin, specifically conjugated bilirubin, becomes prevalent in the blood, it deposits in the skin, and this causes an irritation that causes intense itching and scratching. And as my colleague said, Dr. Manrique, that it is an unrelenting burning sensation. So no matter how much you scratch or itch, it won't go away. So, and for how and why, we're not really sure why some patients get it while others don't. Because some patients have very elevated bilirubin, but they do not have this itch, while others have mildly elevated bilirubin levels and they do have the itch.
I have to admit, when I must have had bilirubin on the mind when I picked this color to wear today. I remember that I was so jaundiced. I had so much bile backing up into my system that my eyes, the whites of my eyes, were this color. And my mother still checks, even though I'm 28 years post liver transplant. And so this is particularly harsh on children. I think for adults, hopefully we have some psychological infrastructure or coping mechanisms to handle this, to have some strategies. But have you met children who have experienced particularly the more severe levels of disease? Either one of yeah.
So for my end, I'm just recently graduated from the American University of Beirut, and I haven't had exposure with liver disease patients. I was a one-off case. I was diagnosed with biliary atresia, but I was a kid when it was happening. So I can say from my perspective, it was difficult because parents and family members would be, no, stop itching. You should stop itching. I was aware, but it's like, even if I stop, it's going to wake me up. It's going to be burning. It's going to be painful. I'm going to be itching. Then I'm going to go have a hot shower and it's going to burn more. So it's just an intense experience that's, again, unrelenting, non-stopping. And I don't think you can comprehend in words. Again, I have psoriasis and it's nowhere near in comparison to what cholestatic pruritus was for me.
Guadalupe, children coping with pruritus?
No, my experience with pruritus, was when I was diagnosed with cholestasis of pregnancy. And I can say that I was fortunate enough to deal with the itching for a very small period. It was a matter of days. And I can tell you that in those days that were in one pregnancy were 4 days, in another were 2 weeks, it was a very, very difficult situation to deal with. And I can imagine a kid going through that under some other paralogical circumstances. So I don't have I don't know any other patient, other kid that have gone through some cholestatic pruritus, but I can foresee how difficult could it be for the kid and their parents.
I think that that's one of the advantages of the Pediatric and Rare Liver Diseases Council, that we can meet each other. We can start to understand how this affects the whole spectrum of age groups, from pregnant women to children to teenagers, like I was when I started, to adults. I think most people don't think about liver disease spanning that entire spectrum of age groups. And I think that's one of the important takeaways that we have. Tell me what you do as a ICP Care Ambassador. I love this idea of having this special attention and resources that you provide.
Sure. Well, I'm the ICP Care Ambassador from Pennsylvania. ICP Care is a nonprofit dedicated to raise awareness about cholestasis of pregnancy, and it offers a lot of support, a lot of resources for the patients and their families. I myself, before being an ICP Care Ambassador, when I started to experience the symptoms, I found that comfort in all the resources the website had. So of course I became interested, and I was a researcher back then. So I became very interested in dissecting the information and preparing myself, because I knew that I wanted to go through, I wanted to have another baby. And I knew that the chances of having cholestasis of pregnancy again were very high. So in my research, I found this nonprofit that has been doing amazing job and not only offers these scientific based resources, but also the mental support for the patients, for the pregnant individuals that are going through this cholestatic pruritus that affects their lives in an unimaginable way.
Do you find that most OBGYNs are aware of cholestatic disease in pregnancy? Are they bringing this up proactively to pregnant people, or is this something that like you had to go out and research it and find it on your own?
I think that as it is considered still as rare, I don't think there is as much noise about it as it should be. Before getting pregnant, I never heard about cholestasis of pregnancy. My doctor never told me itching can be a warning sign. This kind of itching can be dangerous, and you should go to the emergency room. That's what I should have done when I started experiencing itching in the palms of my hands and the soles of my feet. But instead of that, I called the nurse and I said, I'm having these symptoms. And the nurse told me, well, itching in pregnancy is kind of normal. So just so you have some peace of mind, I will schedule an appointment for you for the next available day. And it was Friday, and I had my appointment until Monday. I was fortunate enough to be seen by a doctor that knew what it was about. And as soon as she saw me, she was like, I cannot let you go because you are almost 37 weeks and this can be dangerous for your baby. So right now you need to go to the delivery room. And that was great. I consider myself lucky. But unfortunately, for other women, it has been a different story. And I think that, yes, doctors should be more vocal about it, more vocal about this symptom that can be really dangerous.
And what can happen to a woman if she isn't diagnosed, if her physician isn't aware, if this just goes on and this signal is ignored?
Well, the major risk is stillbirth, meconium staining, and some other respiratory issues for the baby. And also the mother can experience hemorrhage. So it can be yes, very dangerous for the baby and for the mom.
This is why we're talking about this, because something that's dismissed as just, some itching can really have life-threatening consequences, can be a signal of very serious disease. Ahmad, you had very serious disease as an infant. Tell us more about your patient journey with you and your family.
Okay, so I have to preface this that I was a patient in a third world country in Lebanon. Lebanon has an excellent healthcare system, but biliary atresia is even rarer than here. So in the
Mhm.
US, it's 1 in 15,000 births. In Lebanon, it's even almost undocumented.
Mhm.
So I was one of the first few cases of biliary atresia back home, and I was lucky enough to have a US trained physician to detect it at 11 weeks old. And the US based surgeon came from the US to Lebanon who did my Kazai procedure. I spent my life with a cirrhotic liver, so you can assume that my
Mhm.
family was, my mother in specific, was very worried, very concerned. She spent my childhood taking care of my diet, my food, my
Mhm.
habits, and I did have the itch throughout this period, but
Mhm.
I was managed. I was managed quite well, and at the age of 16, I developed hepatopulmonary syndrome, and I was on an oxygen tank. At that point, it became severe, very severe. So I was constantly itching every other day, waking up with the itch.
Mhm.
Uh, I the thing is, even physically, it's painful and stressful, but mentally,
Mhm.
it's tiring and it's not nice. So because I would be sitting with friends and I'd be itching like a rabid dog, which is not a nice appearance, but I couldn't stop. So
Right.
I'd be sitting with people, talking to them, and I'm scratching my shins. It was mostly
Mhm.
my shins, and my parents would really worry and be stressed. Eventually, I had my transplant outside my country. I had to travel. It started improving, but I had a rough post-transplant journey. So very briefly, I got a rejection within the first month, followed by CMV, EBV within the
Mhm.
second month, and by the fourth month, I was diagnosed with non-Hodgkin's PTLD. So
Mhm.
I had to undergo a lot, and throughout this journey, pruritus was a friend that tagged along until my liver settled. So it is one of those symptoms that you do not forget. I remember
Mhm.
clearly the days I used to go to shower after having severe itching, and my legs and feet would burn. I'd see some blood because I was just constantly itching my feet and my shins, and it is something that people should be more aware of. I tried many things to relieve the symptoms. Some things worked, some things didn't, but
Mhm.
it's a constant annoyance that's always in the back of your mind that wakes you up at night just so you can itch.
Mhm. We're so grateful to have you here. I realize in so many um, points in that journey, we could have lost you, and we wouldn't have you as a transplant hepatology fellow today, focused on solving these problems. I remember absolutely. Keeping mittens on my hands so that I wouldn't scratch and injure my skin. Ice, rubbing ice all over to try to cool some down. Cool showers. Experimenting with a dozen different types of lotion, but really it was debilitating when you think about having to concentrate on schoolwork or sleep through the night, which if you can't sleep through the night, that affects everything. It really is a huge limiting factor for participating in life for someone with pruritus, particularly in the extreme um, levels. So what do you want, as you're now talking to other doctors, what do you want them to know? What do you want them to know about how to diagnose it in their patients, or how to be more empathetic to the situation? What do you want your fellow med students and physicians to know?
So this encompasses most of liver disease. I want to bring more awareness to the issue of transplant and rare diseases.
Mhm.
I'm also very considering about uh, the adolescent and young adults, people
Mhm.
through your experience, Dr. Manrique's experience, people who are not elderly patients, who are
Right.
misdiagnosed or ignored because they're considered young, healthy.
Mhm.
What could go wrong? I want to create a voice for these people. Pruritus is one of the several issues I've been discussing, that there should be a listening ear. These patients should not be ignored. The pruritus issue is severe, and there should be a more concentrated effort
Mhm.
to look at these, because when you're at a point in a transplant, it's a life or death situation. So
Right.
my the physician I work with, Dr. Lisa Van Wagner, says this beautifully. She says, you go from a life-threatening disease pre-transplant to a chronic disease post-transplant.
Yeah.
And this is true, but physicians get hooked up with the issue of the patients might die and they forget the small inconveniences of daily life. And this is something I want to bring up, that no, the pruritus is annoying, the nausea, the other complications that are not just life-threatening complications, these complications that just make the day worse, make your time on the mait list worse.
I think that's absolutely true. That there has to be a life that a patient worth living. And if you're taken sort of out of yourself with high levels of pruritus, it really can really drive one to the point where you question things, and it seems harder to go on and do the things that you may need to do to sustain, to be able to make it to transplant or other therapies. I also think that you raised two points that I want to highlight. One is the ability of sharing best practices in diagnosing and treating rare liver diseases globally. Certainly in the US, but really being able to make sure that no matter what country or what health system someone is, that parents and families and physicians have the resources to be able to diagnose these diseases and to connect to treatment. And so smoothing out and making sort of global accessibility an issue is something that I'm excited for the GLI Council to take on. The other thing is patient-centered research. You talked about more awareness, more attention to solving this problem, and as patients identify the issues that matter to them, it's exciting to see more research in this area, more research on alleviating symptoms on the way to treating diseases and creating cures, and giving some of that research equal weight and attention. And I think that's really because patients have brought it to the forefront. Guadalupe, what other problems would you love the health system to solve? What are some other gaps in research or knowledge that you think that we should pursue and fill?
Yes, I think Dr. Mott raised a great point, which is how mentally detrimental itching is. The fact that you cannot sleep and how that can affect your daily life. You don't have that time in which your body recovers, that your body needs, that your mind needs to work every day. So the next day you are exhausted because you have been waking up the whole night. You cannot rest, and that affects your life in a very hard way. So I think in my experience, I was very well taken care of physically. I went to my doctor appointments. I was eating well. I was exercising, but nobody told me you need to take care of your mental health because this is going to be hard, and you need to look for ways that can help you to just go through life while you are dealing with the itching.
I love to hear those sounds of success. No, I think love little voices. That is a sound of successful treatment. That's what this is all for. So
yes, definitely.
that makes me smile.
I consider lucky because both of my pregnancies were successful, and it was hard. And yes, after my delivery, my second delivery, when I thought I am prepared, I have read everything, I am taking care of my diet, I am exercising. After the delivery, it was like the bubble I was just broke apart, and all my emotions, all that fear and the anxiety and the exhaustion of the everyday life for the last weeks of my second pregnancy was very hard to deal with. And I wish doctors could be a little bit more aware of how itching can affect your life, your mental health. That I think would have been very helpful. And if I could just go back in time, I myself would be paying attention more to my mental health. I would go to therapy. I would like try more mindfulness or things that could help me just to cope with the fact that there's nothing I can do to get relief.
I think that's important. The different techniques and modalities to help people put the pain, the suffering in a different context. That can, only go so far until you actually treat it. But I definitely see that people's perceptions of pain, people's perception of the burden of itchiness, can be managed, particularly when it's acknowledged that this is a real problem. I think that's perhaps the start of things. You talked a lot about your diet. Are there particular foods that you found helpful in reducing the itch, or just making you feel better? We're always have a lot of questions about liver healthy diets and nutrition questions, but is there anything you found helpful?
Well, not really. I mean, I was hopeful that I could, if I was healthy, I could avoid ICP for a second time, cholestasis of pregnancy for a second time, but I couldn't. But of course, I was trying to just to eat as much veggies and as healthy as I could. Yes, I didn't experience any other health issue apart from cholestasis of pregnancy. So I think that, of course, exercise and a healthy diet help, because there are some other health problems that can appear in pregnancy that can be associated to the type of food you are consuming. But fortunately, it was just cholestasis. So I want to think it helped, but definitely it didn't avoid the itching or the illness by itself, the condition.
I think that's so important to realize that even for someone who was doing everything right, and had researched and educated and was exercising and eating well, this is why we need medical attention and innovation for this condition, because it is a serious medical issue. Ahmad, as we close up, what do you hope for patients in the future who may experience cholestatic pruritus?
So one of the things I want is patients to voice their concerns and their opinions. I think patients, especially patients on the transplant list who have much bigger concerns, I even did that, tend to ignore the minor problems. Even as a patient, you're not concerned as much about the itch on the long run as about living the next day and getting a transplant.
Right.
But no, I think it is important to voice your opinion, to say what you're feeling, and to push through, because these minor inconveniences can make the whole waitlist time different, can make your life a bit better. So that's one thing. The second is always for patients to communicate. If one doctor doesn't hear, that's not your problem, that's a physician's problem. Talk to another physician. It's okay. I know a lot of people have an issue with patients reading up on Google about their symptoms and everything, but I think using the resources correctly is a very good plus for patients. For patients should have the opportunity to read, to be given links, websites, brochures about these symptoms, and should be open to talking about these things and trying different ways. There are some available medications that are being tested, some different diets, creams, emollients. All of these could be discussed. The time on your wait list or the time with this symptom should not be debilitating to your whole life. In the end, it's an itch, and we should find a way to manage it properly.
Absolutely. And that's why we're doing this series and curating resources and partnering with, programs like Ditch the Itch. I know our colleagues at the European Association for the Study of the Liver are also doing webinars and information. It's very exciting to have catalyzed this energy around a patient-defined problem. And so I think the voice of the patient in not only identifying issues, but in co-creating the solutions is something that we are honored to support. And with that, I say thank you so much for kicking off this series. It's been my pleasure.
Thank
Likewise.
you.
Thank you so much.
Thank you.
Hello and welcome. My name is Donna Cryer. I am the CEO and founder of the Global Liver Institute, which is the convener of the Pediatric and Rare Liver Diseases Council. And I am so honored to be hosting this conversation as part of our Conquering Cholestatic Pruritus. It's a mouthful, even if you've had it, as I have. To unpack, we are going to be sort of discussing myths and management of itching, basically the extreme itching that accompanies up to 70% of cholestatic liver disease, with some world-renowned experts. And so let me introduce them to you. I have had the great privilege of enjoying some conversation with them, and I'm excited to present them. So Dr. Saeed Mohammed is a pediatric transplant hepatologist at Monroe Carell Jr. Children's Hospital at Vanderbilt in Nashville, Tennessee, one of my favorite places. And Dr. Ahmad Anuri, who helped us with our earlier patient panel, is doing double duty for some of the physician experience as well. And so he hails from Dallas, Texas, where he is doing his postdoctoral fellowship in hepatology at UT Southwestern. So welcome to you, gentlemen.
Thank you for having us.
Thank you. It's good to be here.
Excellent. Dr. Mohammed, can you just give us some background? People may only be watching this section. And so what causes pruritus? And what does a typical conversation with patients who experience this look like?
So pruritus is something that we see commonly in patients with all types of liver disease, and particularly cholestatic liver disease, or those where the bilirubin is elevated. At this time, we don't know exactly what exactly is causing the pruritus, but we do suspect it is something in the bilirubin. Now, bile acids have been a prime suspect, so that is something that is often tackled. There may be other substances in bilirubin. There's something called autotaxin that's also suspect. So right now it's not clear what the exact pruritogen is, but all the treatments that we've had so far for this have been trying to either decrease the bilirubin or decrease the bile acids or interrupt the bile acid recirculation to improve the pruritus, or even I'll say just symptomatic treatment of pruritus with things like antihistamines, which don't really act in the bile but act kind of broadly.
And so that might be like Benadryl, for example.
Exactly.
Which frankly puts me out. They offer it. I have IBD in addition to having had PSC and a transplant, and it's often offered as a pre-med to my infusion. And I'm like, no, I wouldn't be able to drive home. I'd just be asleep here in this chair. And so individualizing options for patients is so important. And so maybe Dr. Anuri, how many different things have you tried to resolve pruritus, this extreme debilitating type of itching?
Well, I've tried quite a bit. I've tried everything emollients or creams I can get my hands on, from just the typical Vaseline to things like vapor rubs to other things with including antibiotic treatments, which is not the smart idea. I was a teenager back then, but I just tried to add anything I could. Cold showers, ice, cholestyramine. At one point, I was on ursodeoxycholic acid, which did nothing. And at even one point, which helped, but it was for another reason, I was on opioids for pain management. It somewhat helped the pruritus also. But I've tried a range of things.
So, you know, I look so often in our Facebook groups and in questions to patients, and I have almost never heard of the one thing working for the same patient, for different patients. It seems like I could have such a long list of the different things that people have tried, from, you know, lotions with oatmeal or things for eczema, humidifiers, cold baths. I know I used to rub ice on my skin. Dr. Muhammad, is there anything that actually works or works in a higher percentage of patients than others?
You know, I think your informal research through Facebook is probably correct. You know, I'll say most pediatric hepatologists have a sort of a system that they use for this. Many of our patients that we're seeing are very young, and so they cannot complain about the itching themselves, but it's their parents. And so we will try what I'd say is sort of first line therapies first. So that would include things like were mentioned, you know, lotions, oatmeal baths, things like that, plus an antihistamine. So that's usually our first line. Now, the basic problem is we don't know what exactly is causing the pruritus, so we're kind of doing symptomatic management. Excuse me. So yeah, we usually start with an antihistamine. Most patients are on ursodiol as well. Like Dr. Nuni said, it didn't do anything for him. I've seen it work in some patients, but temporarily. But otherwise, it's, you know, most people think it's fairly safe. It's thought to be to help the bile get out of the liver, and we do suspect that it is something in the bile that's causing this. And so, you know, we want to get the bile out of the liver and into the intestines. And so that's the ursodiol or Actigol is one thing, plus antihistamines. And then there are other tiers of medication that we'll use. One is, rifampin, which is an antibiotic that, I think, works pretty well, again, for a period of time before the patient kind of gets used to it. There are some sort of antidepressant type of medications that work on the serotonin receptors that seem to work in certain patients. Maybe some opioids may help. I really never use cholestyramine, but I know in the adult populations, they use it a little bit more often. It's just difficult to take and space out your medications for it. So, there are no great medicines for cholestatic liver disease. However, I'll say in the last year, there have been 2 medications for the same class that have been approved for pruritus, but not in all cholestatic liver disease, in specific diseases.
So more research needs to be done to make sure that it's applicable or generalizable to other types of liver disease.
Yeah. So, for Alagille syndrome and then PFIC, they both have medications which are approved for pruritus reduction. And in their clinical trials, they have shown some improvements in pruritus. So they've used a pruritus scale, usually filled out by the parent, and have shown improvements in their pruritus or itching. So in those 2 diseases, there are FDA-approved therapies now. So all the previous ones we've been using have not been FDA-approved, but these two are. And I know they're conducting trials in PSC, in biliary atresia, and maybe some other diseases as well, to try to see if it's applicable in those as well.
I think that's one of the reasons, well, I know since I founded the council, I don't have to imagine, it is one of the reasons why we created the Pediatric and Rare Liver Disease Council at GLI, to identify issues like pruritus and research gaps, which could serve a larger number of pediatric or rare liver diseases, and sort of elevate those in the research agenda collectively in a way that perhaps one disease, one small rare disease alone couldn't do, and to make sure that as many conditions as possible could benefit as quickly as possible. And so being able to do that research so that others have an FDA approved medication is really important. I know that it must be heartbreaking to see these little children who are just, itching so much that they have, broken their skin. And Dr. Nudi, you were one of those children, and so it must be very exciting to be able to see advances in that. How can patients help in the research? Is one of the things that I have. Are there things about, you talked about itch scales and parents and patients providing that information? Are there ways that parents and patients can do a better job of describing or characterizing or measuring pruritus so that their doctors and researchers really understand the reality and the severity of this particular condition? Dr. Mohammed, can patients do a better job of reporting this?
I hate to put it on the patients. So many patients who have pruritus, they've had it since they were very young, or since they were born, and so as they get older, they tend to get used to it. Right. And probably don't report it as much. Like if something is your baseline and you go to the doctor, right, and they ask you how you're feeling, you'll say I'm the same. So I don't think there's anything they could say there that to sort of characterize their itching more. I think it is more on sort of the medical community to really ask more questions. So, itching is something that you do, but it can also affect a lot of other things in your life. So it often affects sleep. So, we should be asking them how their sleep is, whether they're eating okay, whether check to see if they're, as pediatricians, we often look at the growth chart. So check to see whether they're growing, because all the things that sort of itching interferes with will affect the normal development of a child. And if they have any kind of skin lesions, I think, that may affect their ability to, sort of to have social interactions. So sort of delving into those sorts of things, I think it's just important to give more time to sort of each patient interaction and ask sort of more holistically, instead of just, are you itching or not? Yes or no. As some kids will just be very fidgety and move back and forth and not be able to sit still because something is bothering them. They may not be able to verbalize it, but there is something that's bothering them. And so I think, it's sort of on us to do that. I personally have not really used the itch scales very often, but I do think now with newer therapies coming out that are sort of more targeted at itch, it is important to document where they are so that you can have a baseline and then know whether or not things are improving. Because otherwise, you can't approve anything by saying, I think, a bunch of people did get better. You have to say, out of 100, 70 went from a score of this to a score of that. So, I think clinicians have to be better informed. And then, not because these are so rare, these diseases are so rare, maybe not every clinician will be aware of these things. So families need to be educated too, that there are clinical trials out there. There are medications that are being tested, and they should ask their physician, like, do you know that this is happening at this hospital or that hospital? And for rare diseases, I really find that families know a whole lot more than me, about what's going on maybe around the country sometimes, because they're in these networks where people are, from the West Coast, from the East Coast, and they hear things from their doctors. And so it's kind of they're having their own sort of, liver meetings online, and they can hear what other people are doing too. So I've had people who've said, I heard that this medication worked for a patient, and as long as the mechanism makes sense, you can potentially think about trying it. So things that I haven't tried very often, but I've heard that they work. If a patient would say, I want to try that because I know several people where it has worked, I'd be willing to try it there.
I remember when patients like me started as almost a sort of a proto registry, if you will, but more on sharing symptoms and patient experiences. And for the first time, other patients in a more standardized way could share what they were using, what they were trying, what the effects were. And I think that growing sophistication of patient-developed measurement is really important to be able to fuel research. One of the things that was striking to me when we in some discussions about pruritus research was that, just as you were saying, some patients it becomes sort of normal for them, or when we were suggesting perhaps tracking itching by wearables, some patients with very severe itch were just very good at suppressing the actions, and so it wasn't necessarily the best or the most accurate measurement of the severity of the itch, measuring the movement, because some had just gotten very good at suppressing that movement. Let me go to Dr. Anadi. If you can continue the discussion on the impacts that doctors should be, having in terms of a holistic discussion with their patients, how it affects sleep, schoolwork. What other things should doctors, try to prompt or think about having discussions on with their patients with pruritus?
I think Dr. Muhammad said a big part of it beautifully, especially asking detailed questions about, for example, sleep. I think sleep is very essential. We should ask for interrupted sleep if patients are waking up to itch. I also think about social situations. Is there a need to, is this itch constantly disrupting you in social areas, such as being with friends, going out? Are you constantly having this reminder or need to itch? Another thing that I personally faced with, and I've heard a lot about, was family members used to comment on, why are you itching so much? Or won't you stop? I was a bit older, so I was 16, 17 when itch was at its peak. So people would be aware of my itching. Sometimes it would go back to the back of my head and I wouldn't be aware. And it's also important to ask family members or loved ones or relatives who are aware of the situation, if they see the patient constantly itching, having any lesions, since you're being taken care of at that point. So these are some added ons you can have. And from the patient perspective, as Dr. Muhammad said, I think the role falls more on the physician. However, I think patients should, I've been a patient, I know how patients go. Sometimes you don't want to be compliant, especially as a teenager, having 40 something medications a day and jumping from one pill to another. You don't want to be compliant, or you tend to miss a pill or two. I think for patients, they should record their symptoms. They should be aware. For example, I took this, I did this, the itch improved by this much, or you know what, the past week after starting this medication, I haven't woken up on the itch. So it's very important for us as patients to be aware of what is helping, what is improving, verbalize these things and be open with physicians and tell them that this is helping, this is not helping. This is something I think from a patient perspective that should also be worked on. This open communication and this hand-in-hand work to treat the disease.
Absolutely, because so much of that information resides outside of the doctor's office, and so this idea of being able to partner to advance the research and the management options, and Dr. Mohammed, your openness to your patients' experience and knowledge is so refreshing. What is it? I wonder if listening to you, Dr. Anadi, if this is often misdiagnosed in children, Dr. Mohammed, as developmental issues or autism. If I saw a child sort of rocking back and forth or something like that, I may not think liver disease as my first thought. Are there ways that we can help our pediatric internal medicine, family medicine colleagues better identify cholestatic disease in children?
I think if you have cholestatic liver disease to start with, I think it's evident that you have it. I mean, your biochemical parameters will support that, but then all the things that go around it. So, like Dr. Anodi was saying, the difficulty sleeping, difficulty in school, difficulty with social situations, those may be diagnosed as ADHD or depression, anxiety and things like that, and they may be put on even more medications to sort of to tackle those problems. So I don't know. I think most hepatologists would recognize that itch can cause all these kinds of things. If you go to your sort of your regular doctor and they know you have a liver disease, I think they would also expect you to be somewhat itchy. But some of the subtle, like maybe some of the way that you cope with this is that you become more anxious, or you become more, I don't know, like more depressed, and your primary care doctor is probably gonna see those and think of depression and maybe put you on an antidepressant, for example. So I think, again, I don't know how to really tackle that, because they can be depressed because of all their symptoms. And the only way to fix it is to get at the root problem, which is your liver disease and your pruritus.
I could not agree. Could not agree more. I remember it just wanting at some points to be sort of taken out of myself. It had gone so far beyond my capacity to tolerate that. I was just, put me out, put me to sleep. I just sort of needed to, just a new sort of psychological infrastructure to be able to cope with it. And I was a teenager and early 20s when that was happening. And so to imagine children having to deal with that without that sort of psychological infrastructure is very hard. And I think that's why we're doing this series, so that people understand the seriousness of pruritus, that it's not just merely itching, and the huge impact it can have on people's quality of life. And so I'm excited that there are new treatments and that there is more research. Dr. Nadi, you were diagnosed and initially treated in Lebanon. How can we make sure that hepatologists in other parts of the world and pediatricians and doctors in other parts of the world are recognizing these symptoms and are being forward with management best practices for their patients?
So this is an excellent point. I think one of these ways is the things we are doing now. I think lecture series, continued medical education, especially in in countries where medical schools and medical centers are available, and they do have a cross between. So back home, in my medical school, many of the physicians were US trained. So there was a cross of these people knowing about the research being done in the US. So if this is available, it will promote physicians to learn more and to study more and to read more about these things. In the US, you're privileged to have all these resources, and you have this capability for research and funding. Back home in a third world country, it's not that prevalent. So translating this work, and especially the internet now giving this accessibility to physicians abroad, is within itself a capability to let them know about the current methods and the way to deal with patients. And this is very essential. And it comes down to each physician on his own if he wants to improve and work on himself. I've had a range of physicians, some who really would want to read and learn, and some who weren't interested.
I think this is one of the reasons why I'm so excited that our communications team speaks, I believe, 5 languages, and we're working on having more of our materials translated into various languages, and even some of our video series like these, closed captioned and put into different languages, so that care is more evenly and equitably distributed for rare disease patients in other countries. So we keep us accountable for that, and help us think of ways that we can share this information more broadly. Dr. Mohammed, does transplant always resolve the pruritus for patients?
It depends. I'll say it first depends on what your disease is. We've just talked about cholestatic pruritus and are not giving sort of any particular, disease processes. So I'd say in the majority of cases, transplant does cure the pruritus. So like I said before, we don't know exactly what the cause is. We suspect it's something in the bilirubin or bile acid transport sort of area that's causing this. So a new liver will treat it. And you won't have pruritus unless you have complications of that liver transplant, such as, rejection, chronic rejection, or again, end stage liver disease, if that happens, or, I'll say in the case of PSC, if there's recurrence. So, that can always come back, but for the majority, a liver transplant will rectify the situation. I did want to talk or touch on something that you had mentioned about pruritus being, kind of, more important. So pruritus is not something, it's not a lab value that we can measure. So when we're following something like a bilirubin, if we see the bilirubin triple or go, go very high, we become very alarmed. Or if we see that their sort of clotting factors have decreased and they're at risk for a bleed, we become very alarmed. We can't measure pruritus the same way. And I don't think it registers in most clinicians' minds as much as a lab value, because that's what we're trained on, lab values, not really on patient outcomes. Then other things like, growth can alarm you, but growth can take a couple of months to become evident as to whether you're having growth failure or not. So, I think it is important to have, I'll say, representation from people like Dr. Anudi who've been through it, who can say, this is really debilitating. Like we cannot let this go on. Even though their lab numbers may not have become worse, if they're complaining of more itch, they're not really living their life, and we have to do something to intervene. Some data out of patients with Alagille syndrome who have probably some of the worst itch shows that many of them who get transplanted, they're transplanted. One of the reasons, or one of the big reasons that they're transplanted, is for itching and quality of life. Of course, there are other reasons, such as, the progression of their liver disease, but itch is still a very important thing with, you look at Alagille syndrome, and it would be great to be able to measure it, or for patients to measure it, but that does put a burden on them and takes a lot of time for them to do. And of course, you can't remember to do it maybe every day, maybe that you'll just remember on the worst days. And so it's, maybe some better methodologies of measuring itch would be really good as well.
I think so. I think that things that cross many different diseases such as fatigue or cognitive function or itch, which are all very hard to measure, but really have sometimes the most impact on a person's quality of life. Those are some of the things that I'm really most interested in trying to be creative, be technologically innovative in trying to figure out how to make it easy for people to track. Most people know I have sort of multiple devices on at any one time, always trying to figure out something a little better to communicate to myself and to my physicians how well I'm really doing, and be a little predictive, since sometimes I run ahead of my numbers, so to speak, and sometimes I run a little behind. And it's been exciting to use technology to get a little better as I'm older in terms of catching myself earlier in the process of a little decline, where we can just give me fluids or iron or something, something like that, and keep me out of trouble before I end up in the hospital or something. And so I think that this era of patient-driven measurement tools and being able to use different types of data to paint a picture of people's quality of life is something I'm very excited about. Dr. Nudi, perhaps I'll let you have the last word, since you are at such a crucial point in your medical training. What are you excited about to be able to bring to the field of hepatology and patients and families like yourself?
So I'm really blessed. My disease is my biggest blessing. I say that. I'm at a very crucial point where I have the means now to look up all the questions I had as a patient and try to formulate some research. So let's disclose this. I'm working, for example, a bit now on biliary atresia research and outcomes, and this has been really exciting for me as a patient, and it being a rare disease, trying to learn a bit more, even if it's a bit of descriptive research, and understanding the field more is something exciting. And all these ideas, and from issues of pruritus to issues of transplant, post transplant diets, to exercise, to lifestyle in general, are things that concern me a lot. And as I'm going through my career, I'm trying to tackle these questions I had as a teenager into real scientific research that could hopefully patients like myself one day could look up and find something more formulated and better researched, to say the least, and they could rely on. I was a very informed kid, to say the least. So when it's not anything, but whenever I had a question and no one could answer, I used to search everywhere, and I used to look through PubMed, and even as a teenager. So now that I have this capability to put some papers on the front and to get these answers I had, I think it'd be beneficial to patients. Researchers really tend to ignore the impact they have, and I think the research is one of the most significant things. Patients' lives changed through research. There are many clinicians, but real research puts front the answers to the questions all these patients have.
That is a wonderful note to end on. Thank you both so much for helping us understand the myths and management options and the future of patient-driven research in cholestatic pruritus. Thank you both.
Thank you.
Thank you. Thank you very much.
Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and we are the conveners of the GLI Pediatric and Rare Liver Disease Council. I am so excited that out of the sharing of best practices and problems and solution identification that happens in those council conversations came this idea and this event for Conquering Cholestatic Pruritus. Certainly as a patient with PSC and transplant who has experienced how severe cholestatic pruritus is being, this is the event that I have been waiting all my life for. And so I hope you have been as well. So this is our third part in the series on what is new and innovative. We hope you do go back and listen to the other parts on the patient experience and on patient-provider conversations around management of cholestatic pruritus or itching. And so I want to welcome these guests that I have, these very special, brilliant people, part of our pediatric and rare liver diseases solutions family, I would say. I have Dr. Marco Carboni, who is an associate professor at the University of Milano Bicocca and honorary consultant hepatologist with the European Reference Network. He is part of the clinical lead for the cholestatic liver disease program in Monza, Italy. And then we have Dr. Emma Culver. When I switch back over to English, I trip over my own tongue. It wants to stay in Italian. But we have Dr. Emma Culver, who is with us from Oxford University in the UK. She is consultant hepatologist and senior lecturer in translational gastroenterology unit. She is also a specialist with an interest in immune-mediated liver diseases, of which is the topic we're here today. So welcome to you both.
Hello, Donna. Thank you.
Absolutely. Thank you. So Dr. Carboni, perhaps I'll start with you with the new before we get to the innovative or the clinical research. What is prescribed, what is approved right now for patients with pruritus?
So I think it's a good moment from a scientific point of view for patients with with all kind of cholestatic liver disease suffering with itch, since there are several trials with drugs disease modifying but also drugs tackling symptoms. So we have at least 2 to 3 drugs tackling itch, which is the topic of this webinar. And up to now, these trials, phase 2 and phase 3 trials, show that there is these drugs are seems to be effective in controlling the symptoms. Side effects are limited, and ideally they should be coupled with disease-modifying drugs in order to treat the symptoms, but also slowing down the disease, PBC and PSC.
Absolutely. So, Dr. Culver, I'm sure that by the time patients get to you, they've sort of tried everything from lotions to urso to cholestyramine, and so how do you start with patients as we enter into the things that you are looking to research and innovate on? But where are we now? What is the current status of treatment?
So I suppose by the time they often come to me, they may have been referred from another secondary centre, or sometimes even come through primary care services, then to a tertiary centre, and they will have tried first and second line therapy. And we will usually move up the kind of cholestatic liver itch pathway in terms of drugs. I think it's really important to engage them early in options for clinical trials. And as Marco has nicely described, there's a number of them available. And so we have access to autoimmune research nurses and clinical trial expert nurses who will screen them against criteria that we have available for those trials. And then we will educate them and tell them about the risks and benefits of these trials and what we might be able to achieve for that particular patient. And that will sometimes account, obviously, for the fact that they may have to travel a distance already coming to a tertiary centre to attend trials, They will come more frequently than they would usually come for regular appointments. And obviously, depending on the trial, there may be a placebo arm of that trial. So they have to be made aware of all of those parts, as well as the potential side effects. But I think that there are great trials that are now available and open for short and longer term periods of time. And we give anyone access to those trials as long as they are interested. And we advertise as much as we can through the patient support groups. People can reach us from various different places.
Well, ensuring that patients have access and information on clinical trials, no matter where they are initially diagnosed, is a really important part of our work at the Global Liver Institute. It's one of the reasons why we convene the various different groups that work on different types of cholestatic diseases to really amplify each other's efforts. So we can better reach patients with trials. I'm interested in what questions patients ask you as you're talking about a trial with them. What are their concerns and questions?
For me, so well, I mean, it depends on the patient, depends on the level of education, it depends on the curiosity, it depends on the trust that the patient has on yourself. I mean, there are people that say, look, if you tell me, I will do it. And people that say, look, you write it down and I will go and study. It really depends on the patient. But generally, what we're trying to do is to educate all of them. So we give them, like probably did in the UK, in most part of in the US as well, to leave leaflet with, so that they can connect with the patient advocacy group of the region, of the nation. And so they get more educated on how it works, what is the disease, how it works, the research, how does the research translate to better care, because dealing with an educated patient, it's easy for us, it's easy makes easy the interaction, and it will make their journey probably less painful as well.
Well, Dr. Carboni, one of the ways that you've done that has been partnering with patients on the development and design of research, from the identification of the questions to the drugs like vancomycin that some patients want investigated, to the design of trials. And so tell us what it's like working with patients as your partners in research.
Well, you need to fine tune in terms of expectation, and you need to show also knowledge from one side and the other side. You need to sometimes there are wrong expectation on what you can do or how you can show that a drug works. And so, but I think of course you need there is a human component that is behind everything, and so you need the right people, and you need good chemistry, and that's the basis of every kind of interaction. And I interact a lot with some of the GLI and from the UK, PAO and the Italian one, and most of the time you find patients that are very it's a mission for them as well. So it's I think they are selected in terms of humanity. So it's we always have a good time in planning how to advertise a trial, or how to send through a message to the patient community. So it's fun. And so we over the last year we planned with some association, including the PAC Pediatric Foundation in the US, a trial of oral vancomycin for young adults and adults with PAC in Italy, and it's beautiful because there was so much engagement from a US patient organization group, and this is related to the fact that we are in a unique globe, and the disease, if we treat the disease, if we sort out these issues, we will sort out the issue for the entire community of patients around the globe. Fundings are very limited, so everyone is trying to help each other. So we created a very nice community working behind this trial. So yeah, it is still a very, very rewarding experience, actually.
Okay. I think it's an important learning process for both groups. The patients to learn, medical and scientific research terminology and methods. We try to help with that in our Advanced Advocacy Academy, and then physicians to help, to sort of change their thinking, to work with patients as peers, and help them translate their lived experience into research questions. And I think it makes both sides.
Yeah, absolutely.
better.
Also to get to know better what is more important for patients is not for granted for a physician.
Dr. Culver, one of the things that we have been discussing across the series are patient-reported outcomes measures and better ways to measure pruritus. What are some of the challenges that you see in doing research and innovating in this area?
Yeah, I mean, I think that's a really important question. And the challenge always with symptoms, whether it's itch or fatigue, is there is some subjectivity to that. And we have seen from early trials that there's a placebo effect with some of the trials too. So I think there has to be quite objective measures that are recorded reliably over time for the purpose of the trial. And actually that can also etch into the clinic too. And that means that there's a good way of being able to objectively assess on each visit whether someone is more or less itchy. And you'll know a variety of different scales, like the VAS scale, that can be used. And different scales have been used in different trials, but overall the whole point of it is objectiveness over time. Both the physician, the nurse who is obviously helping with the trial, but also for the patient to get an understanding. And I think that's important in terms of feedback both ways.
So issues like itch and fatigue that you mentioned, pain, are highly subjective. They can change even for the same person over time and circumstances, certainly. And then, of course, variations across patients. And so you mentioned different measurement tools and things between clinic visits. Are there things that patients have at home or available to them on a daily basis that can help, improve the quality of the measurement and increase the precision of how we're doing this work?
Again, a very important thing as well. I mean, one of the things we've been trying to roll out is something called True Colors, which is something that we applied to the IBD community initially, been using in the UK and elsewhere, to be able to track at home via an app your symptoms and how they may vary at different time points, which can relate to your clinic frequency as well as the key areas that we want to address in the clinic time that you have, which will either be face-to-face or phone, depending on the patient. And we're going to incorporate some of the PROs that are associated with PSC into that to try and incorporate itch and fatigue and pain, as you said. It's not a completely smooth process because, as you say, things are very different at different times. But I think it's a start to be able to develop something that can be used at home and that can be fed into a system where we can analyze it. And that's part of our BRC theme at the moment in terms of incorporating it into the inflammation pathway. And I'm sure there's other ones that are available elsewhere to do that.
Great. So with something like itch, what does a placebo arm look like? And how are patients comfortable being in the placebo arm? Are they incentivized or motivated by the ability to change the field, or help me understand what the conversations are as patients choose to participate?
I'll go. Well, I mean, the risk of ending up in a placebo arm is it works for symptoms, but also for trial, just tackling the disease, where actually you don't have a clear feedback whether the drugs works or not. And indeed, I think it's very nice. The proposal is starting to become more to hear more and more on in clinical trial using for drug disease modifying drug using synthetic placebo arms, actually, using for PBC. This is being done, actually, putting together the work, FDA as advisor and all the consortia work in PBC. So creating a synthetic placebo, historical cortisol placebo, and treated the groups. So I think this is something if this kind of process gets validated, I think it's very useful, because it's very frustrating for us as a their clinician and for patient they might think they are just guinea pig, and probably the drug doesn't even work. So it's sometimes you got up specifically in trials with itch. Sometimes you find some placebo effect, and this tells you a lot about the symptom. But it's sometimes we struggle when the symptom is still there. We struggle to keep the patient in the trial, and so it requires a lot of motivation. It requires a good selection of patient, actually, in terms of you need to sort of select patient based on also on their resilience and in their motivation. And most of the time they manage to remain there. They know that it's something that lasts just for a period, and they might eventually benefit of that molecule if that works.
I think that's very important to think about, that sense of resilience. I've done a lot of my work in trial retention as well as recruitment, because it's one thing to get someone into a trial, but how can we support them in staying in the trial until we can get the data is very important. So having that sense of community and commitment to the research beyond yourself is an important part of that. Dr. Culver, what are you excited about? What's coming up? What are you excited about and seeing?
Put me on the spot. I mean, I think there's lots of fantastic novel therapies and trials that are currently open for PSC that weren't sort of 5-6 years ago. And the field is moving so fast, and we are being able to risk stratify patients better. And I think the fact that these trials are open not just to look at disease, but targeting different pathways that might do that, as well as targeting symptoms, is something that we should all be celebrating, actually, because I think that the pharma companies and the physicians have listened to the patients and realized that it's not just about getting to the point of transplant or decompensation, it's about dealing with all the bits in between. And many of the drugs that we have seen some success with in early trials actually do sort of a bit of both. They might help itch, but also might help progression too. So it's choosing the right patient for the right trials, the right endpoints in those trials, the right period of time. And that's kind of our responsibility with our patient advocates to kind of guide us so that we can only go further to improve the trials that are available, but also the patients who can enter those trials. Because at the moment, there is still quite a select few patients, and it would be nice to open it out more, as we have seen in some trials that have come through, to the wider community.
Absolutely. I've definitely heard from patients who are excited about and hear about research in sort of adjacent areas or diseases and want to participate. And so being able to create those research those research opportunities for patients, I think is important as we try to create a culture of participation in clinical research across liver diseases. What are the key questions that we're trying to answer? Certainly, what causes itch, what drives itch, what will keep you from needing a transplant? What are the key research questions that we're trying to answer? Dr. Carboni, maybe start.
Well, I mean, there is a big line of research on the basic concept of the physiopathological processes behind itch, and probably Emma is more expert on that. And then there is a big clinical line of research on what are the specific, the best target to tackle itch. So we have already approved. We have molecules that are already recommended by clinical practice guidelines. And it was an amazing news, actually, that, for example, bezafibrate was proposed by the European guidelines as a first line of therapy. It's even better than the historical drugs like cholestyramine, rifampicin, and this is, I think, that was a very brave decision, supported by an important clinical trial showing efficacy of a drug that can work also as a disease modifier, and that is one target. There are other targets, tackling the bile acid homeostasis and the bile acid reabsorption from the gut is another important target, and I think this is something that we are exploring more and more, and I think it's we should also explore whether this approach might work as also in the might tackle also the disease progression as well. That would be interesting, because as Emma said, it would be ideal to have a drug that tackles both processes, symptoms and disease progression, and ideally even fatigue. Maybe in improving itch, you can also improve. We saw that the night sleep improves, and so fatigue sometimes can be relieved.
As someone who works very hard, something that relieves fatigue is always of interest, and it's amazing the number of patients who've talked about the importance of cognitive function, even over physical function sometimes. And so how can patients sort of send in or connect their research questions and queries, either through advocacy organizations or directly to you or through their doctors? How do sort of patients enter the sort of formative side, the picking of the endpoints, and the developing of patient-reported outcomes measures? How do patients find those opportunities? We present some, but I wonder how they get to you.
Yeah, I think from our perspective, at least, through, as you say, the patient support groups that are available, because actually most of the patient support groups that they can access actually will give opportunity for not just the free speech, but also sessions where they can either meet the experts, they can come to patient public involvement events. And we are very open as individual organizations, and also I think as an international organization for PSC, and as I say, local in terms of UK, US, elsewhere, at being able to take patients' ideas and develop those ideas, because actually without those ideas, we're aiming for a goal that doesn't necessarily satisfy our patient population. At the same time, we have to balance that with what we can achieve, because as we know, patient expectations sometimes with regards to being able to make symptoms completely go away or be able to do something that there is no objective measure for gives us a challenge that we can work towards, but may not be the primary outcome, for example, of a trial, but are very important secondary outcomes, or something that we can eventually incorporate as a primary outcome, as long as we keep things like, fibrosis progression and events as part of it. So I think patient groups is one of them. And actually there are big centres, as we all know, which do a lot of the trials. And I think that there is always good opportunities to access, the consultants and the groups of individuals who are part of the big advisory groups, either directly or indirectly. And we're interested to hear what they say.
What has been the role of patient registries? I know, the PBC Foundation produces a lot of data, PSC Partners, Seeking a Cure. So that has definitely been a change in the past several years of patient groups coming not only with ideas, but with data. How have patient registries changed how you do your work?
I think they have the massive impact on research progression. So most of the big consortia in PBC and PSC were born after, thanks to the genetic study, the genome-wide association study back in 2010. And because for this study you needed huge cohort, and this was the base to create this large cohort, and then enrolling patients from several centers from the same country, including secondary center also, not GI specialists deeply involved in the care of cholestatic patients. And like that, we put together several thousand of patients, again at the national or international level. So there are several consortia. If I in PBC, the big consortium PBC are the one from the UK and the one like European, North American. They get great help for the registration of the first line, the second line therapy in PBC, and they are trying to also to do sort of comparison study with the all the drugs available. Without this kind of consortia, this will never be possible. Also, particularly the national registry, they are good because they engage people. Also, again, the general gastroenterologist, and so they are allowed to really capture what is the epidemiology of the disease in a country. So in Italy, we don't really know how many PSC patients we have, because from it was considered a very rare disease, but actually now we are with the national registry, we can see we go over the several thousand patients with the disease, but we were not aware about it because we didn't have any kind of network to capture this. Another major aim of this is to test to run phase 4 studies for drugs that are to provide real world evidence on drugs that are on the market that sometimes have access to the market with a conditional approval because we do not have a very good hard endpoint in both cholestatic disease. So you need confirmation from real world experience. And last but not least, you can monitor through the national register also the disparity in the kind of level of care that is provided. So now you can monitor, for example, how many patients requiring second-line therapy in specific region are present compared to the benchmark region. And you can do this kind of I think Brits are already ahead of 10 years. They already published this, and it was an incredible difficult work, but very important. They highlighted all the major gaps in this field in terms of care provided for cholestatic patients.
Great. Dr. Culvard, would you like to talk about some of that research in care and care disparities? I had wanted to pick up on the diversity in registries and in clinical trials, but this diversity and disparities in care is also an important topic.
Yeah, I mean, I think, going on from what Marco said, we've definitely recognised, looking at our patients across the UK, that there is a degree of disparity in care, and that is somewhere linked to the main, I want to say, hubs. So the main centres, the tertiary centres, the transplant centres, where people who have an individual interest in, for example, autoimmune or cholestatic disease may sit, and you have a single hepatologist who is managing that with small hepatologists, as opposed to some of the more district hospitals who will have, a single more general hepatologist. And part of the challenge is knowing when to refer a patient into what we call a hub. And so we have set up very much what we call a hub and spoke model, actually coming on from the viral hepatitis era, whereby there was viral hepatitis drugs being prescribed as part of ODNs in a hub and spoke model. And we've tried to deliver that for autoimmune liver disease, and we've had autoimmune hubs almost, whereby patients will be referred in, discussed locally at MDTs that may or may not be a transplant centre, and is therefore given not just for prescribing of certain drugs, but also for clinical trial availability. And also, therefore, we're very happy to see patients as long as they're wishing to travel for a slightly more expert opinion, or indeed to engage them in recruitment trials. And I think that model is set up nicely because of recognition of the fact that there is different parts of care in different places. And we have to acknowledge it and work with patients and also other clinicians who see the disease less frequently.
I think that's so important, and it these conversations help create the advocacy agenda for GLI. So to be able to properly characterize the prevalence of the disease is, as you said, Dr. Carboni, we need to make sure that diagnostics are reaching out into rural areas and into different countries, and then feeding in to people being able to get care through hub and spoke models, things like Project Echo here in the U.S. and scaling, so that access. So we even understand really how rare or how common these diseases are, to to have research investment scaled appropriately, as well as understanding how many treating physicians we need and how many nurses. And so I always think that being able to accurately capture the scale of the problem is an important first step, that in too many liver diseases we don't have that information. And so I think that that's really important that we gather, and as we learn that these rare diseases aren't as rare as we thought they were.
Yeah.
And that holds huge potential for research in the future. So maybe I will just end with the last round of question to you each of maybe what is the research question or research project that you would most like to have funded or advanced, or that you're having challenges in, that maybe our larger network can help you most with? What would you most like to be able to solve, Dr. Carboni?
Well, something that I will never be able to solve is what is the cause of PAC, for example. But something that I can contribute to is some trying to identify some what can be biomarkers of disease activity, and this, I think, it's a fundamental step in order to then test new molecules and trying to change the care of this patient. Something that can allow us, because there is something we see in clinical practice we can't really give a shape. So we see that there are different kind of phenotypes, and we see them, we can write them, but we need in order to describe better all the subphenotypes of the disease, that can give us some hints on disease pathogenesis and how to treat them better. We need to get together, and you mentioned registries, but also I will say the national work, also collaborative work outside the country, because we're talking about rare disease. And something I'm positive with is that I see lots of funding opportunities in rare disease, in cholestatic liver diseases, and this is obviously mandatory if you want to work in this field. So I'm what I said to our patient is that I'm very optimistic from their present, and in particular for their future, particularly to the young one.
Excellent. Dr. Culver, what's next for you?
So I guess the big frontier, and I feel that this is one that the patients care a lot about as well, is the range of patients who go on to develop cancer. And I think one of the big things here is the fear of cholangiocarcinoma. As much as we are screening for and can remove a gallbladder, and screening for bowel disease and can remove a colon, I think the challenge of recognition early and risk stratification of patients that may go on to develop a bile duct stricture and then cholangiocarcinoma, where there is now kind of options potentially for transplantation, for surgery, which weren't available before. I think that's really the crucial next frontier. And there's some lovely work that's out there at the moment, and that we've been trying to contribute to through our BRC with regards to sort of multi-omic analysis, so looking at the microenvironment rather than genetic alterations in the blood, in the bile, in the urine, to see if there is biomarkers, as Marcus said, for disease progression, but also looking for biomarkers of cancer, and teaming up with kind of quantitative MRI studies to have a look directly at those objectively, those strictures, and see if there's anything that we can pick up that might be able to identify those patients early, so that we could expedite their care. So I think that's the other frontier of things that we've got to work on. And as a big international group, we've started to recognize some of those risk factors. But now I think it's down to looking at the biomarkers in the blood, bile, and as I said, multiparametric MRI and well-defined cohorts, and validating that again so that we can tackle that frontier next.
That's fantastic. If this doesn't attract more young researchers into GI and hepatology, I just give up. I don't know what else could do. This has been an excellent conversation. It's given me hope as a patient and hope to so many others. So I thank you so much for all of your work and for this conversation today.
Thank you, Donna.
Yeah, thank you.